My name is Nirvana Manning, and I am the chairman and service line director of obstetrics and gynecology at UAMS. And I have the opportunity to be a part of your Green Rounds, and I'm super thankful for that. Um, I was asked to kind of just speak with regards to what we can do to increase the rates of maternal mortality in our, excuse me, improve the rates of maternal mortality in our state, and what's kind of being done on this front and on a statewide level by us and our colleagues around the state. So I want to keep this as interactive as possible. I'm going to kind of go through some slides that show where we've come, what the issues are, what we're doing. But if there are questions that relate specifically to your practices or concerns that you guys have with regards to these issues, which are super complex, please reach out on the chat and just let me know. So improving the high rates of maternal mortality in our state. So just as a little bit of background, maternal mortality, which you guys may have heard about a lot in the news right now because it's certainly receiving a lot of attention. Arkansas is ranked number 50th with regards to maternal mortality. It's estimated that 30 families in Arkansas every year suffer from pregnancy-related mortality, and that is not total number of maternal deaths, but with regards to pregnancy-related. In 2018, this was the first year that we were able to review some data on the Arkansas Maternal Mortality Review Committee. This came to fruition based on legislative initiatives. It started in 2019, the Maternal Mortality Review Committee, and we looked at our first data set, which was 2018 data. We are now current date to mid-2021 data, and we hope to get much more real-time data as we go forward. With this committee, we were able to discern that probably 92% of those maternal deaths in our state could have been prevented in some way, shape, or form. And that sounds like a very daunting number. And I think colleagues throughout the state, including myself, hear that number and are not only concerned, but goodness, what are we doing? And so just as a little bit of background, when we look at these cases, and I sit on that maternal mortality review committee, when we look at these cases, I would hope that a suicide or a homicide could be prevented. Deaths from mental health issues could be prevented. So the rates of prevention and opioid overdose that occurs at 144 days postpartum could be prevented. So we cast a very wide net with prevention, and it's not necessarily just what happens within that hospital stay. And I can go into that a little bit more and how we look at that as a committee. But I think what is extremely daunting is that for every maternal death, there is a significant number of mothers that have severe maternal morbidity. And we define those as unexpected outcomes of labor and delivery that result in short-term and long-term consequences for that woman's health over the course of their life. Some very conservative estimates say that for every one maternal death, there's anywhere between 10 to 25 mothers that suffer from severe maternal morbidity. So to break that down, probably 1 in 50 women that deliver in our state have severe maternal morbidity that requires some sort of ongoing care, probably for the duration of their life. We also know from national data that poor maternal outcomes are worse in women that are in rural areas, low income, and non-Hispanic Black women. This suggests that there's a lot we can do to better the health for these women and maintain healthy pregnancies for them and their children. So there are several key things in maternal health where Arkansas is behind the rest of the country and where there's a lot we can catch up on. The first is preterm birth rates. Preterm birth can be reduced by ensuring that women have healthy birth spacing. They have good access to contraception and they have strong social supports in their pregnancies. The second is maternal postpartum depression. Almost 1 in 4 women report symptoms of depression, anxiety after birth. Postpartum depression is highly treatable, and there are even prenatal programs through most of our state that can help prevent postpartum depression in women at high risk, or at least treat them. And finally, teen birth rates. There has been improvement in national teen birth rates, but Arkansas is still the second highest teen birth rate in the country. Teen pregnancy, as you guys know, has profound long-term social and economic costs for the family. Only 1/2 of teen moms graduate from high school. And what we do know is that almost 40% of young girls that deliver between the ages of 15 and 19, almost 40% will have another pregnancy within 18 months. So improving just these three would certainly be significant improvement with regards to this. Now, that's not as easy as it's said, and certainly there's so much in efforts throughout our state kind of working with each of these three buckets. Okay, so here is a big challenge for us, and this is access to maternity care providers throughout our state. And you can see that where the care is concentrated in areas that have very little to no access to care in our state. When we started the pandemic back in 2020, we had 39 delivering hospitals. Shortly thereafter, that 2 of our delivering hospitals closed to 37, and now, most recently, 2 more additional hospitals have closed. So we are at 35 delivering hospitals in our state, which has a very profound impact. For every delivering hospital, especially in these rural areas, that is now a desert. These patients have to travel longer, farther. There's no access to care. And for most of you, you know that pregnancy is a very finite period, but during that period, it requires very consistent care to have the best health outcomes. So every time an area closes, we now have an area of patients that just do not have access to care. And there's so many other constraints in our rural areas with regards to transportation and the ability to seek kind of good health care. So progress. What are we doing to address some of these things? And there are some really great efforts that are going on. And as terrible as it is that Arkansas ranks so terribly, it has brought a lot of national attention. And with that, it's brought a lot of resources. And so we have really tried to capitalize on a lot of some of our grant opportunities in this area to see how we can make improvements. And as I will kind of go along this journey of what we are doing, what we have realized in the Maternal Mortality Review Committee is there's 3 big buckets of things that we can address. And probably we consider a maternal death up to 365 days of delivery. One of those big buckets, about a third of those maternal deaths are happening within the hospital stay. And so that is access to high-level specialists, blood banks, the ability to handle an obstetrical emergency, the ability to work on some of those things just acutely within that hospital stay and surrounding that delivery. The second bucket, the big bucket, is from 1 to about 42 days. And that really encompasses some of our maternal health access issues. They may deliver in a tertiary care center and then go back into a rural area, and who they present to, or if they present with certain symptoms, may not have seen these things, may not escalate that care, may not take them as seriously as they may need to be based on those symptoms. There's a huge campaign that ACOG is doing called the Hear Her campaign, and it really concentrates on some of those high utility things that we see that are really causing this morbidity and mortality, and those are hypertension, cardiovascular disease, cardiomyopathies, and delayed hemorrhage. So that's that second bucket. I think that third bucket is from that 42 days on to 365, and that really encompasses a lot of our mental health, our opioid and other substance abuse issues, which also incorporates some of our suicides. So I think kind of breaking it down into those three buckets allows us to better address them because they really are unique in how we can kind of tackle some of the things that will make a difference later on. So like I mentioned, in 2019, it was approved, and in 2020, we established the Arkansas Maternal Mortality Review Committee. This is appointed by the governor. This is not a paid position. We have people that serve on this committee from all aspects of kind of maternal health care. So I have the opportunity to sit on there. We have MFM, we have anesthesia, we have cardiology, we have social work, we have EMS services, we have our certified nurse midwives, we have the health department. It is a true myriad of people because as we talk about each maternal death in our state and establish whether there was prevention that could be addressed in this case, we make, overall recommendations of things that we could potentially improve upon. And so getting the input from all the players is really important for this. We also have a maternal perinatal quality review committee, and that's a handful or a mouthful to say. But this we share with other leaders in the neonatology and our pediatric world. How can we take that continuum of maternal health care and infant care and really improve it? And there are really unique things that happen throughout our state and the rural aspect and the urban aspect. And so we get leaders from all of those areas to kind of speak and talk to things that we can improve along a quality continuum. Lastly, and we're really proud of this, I'm not proud that it's the 48th state, but at least I guess we are not the 50th state. We joined the AIM Alliance. This is the Alliance for Innovation in Maternal Health. We were the 48th state to join this AIM Alliance. This started from the California Collaborative Care Bundles. So if you're not familiar with that, California Collaborative created these bundles in healthcare. And it basically is such that we don't have to kind of think out of the box or off the cuff with regards to some of these things. There are bundles or kind of toolboxes that are created for some of these obstetrical emergencies. And with that comes a data piece. And so we joined the AIM Alliance, and by that, we have agreed to kind of follow these bundles and collaborate our data as a state to see how we can do things a little bit differently or better. And I'll talk a little bit more about this in just a minute. So one of the huge grants that we received was this Perinatal Quality Collaborative, and it really marries well with the AIM Alliance that we joined. It's 1.2 million over 5 years, and the idea is that we will help our surrounding hospitals implement these AIM bundles. We go into local ERs, we go into other physician offices. As you guys know, working in a hospital right now has its own set of very unique obstacles, many of which, is nursing and provider turnover. Sometimes, these never events in some of these surrounding rural hospitals may occur every 2 years. Well, that's not the same nursing staff. It's not the same ancillary staff that was there 2 years ago. They may not have ever even seen an obstetrical hemorrhage or postpartum eclampsia or any of these things. So how can we best equip them to know what to do, act quickly, and have those resources at their fingertips. So we are going in and helping them have the tools such that, for lack of a better word, they can open this toolbox and know exactly what to do, even if they've never seen it. We're also going into local ERs. There will be a data collection piece that we can then use to help support areas that need it better or differently. So this is very exciting work, and I think with data, we can see how we need to evaluate different areas of our state differently. So this Angels program, some of you may be very familiar with. This is part of my daily practice. It started in 2003 and it's with a contract with Medicaid. And it develops this matrix throughout our state with which you can get some of this quality referral sources as well as consults, and it kind of just collaborates that care in a different way. We create these evidence-based guidelines. There is a tool in Epic for anyone that needs it. It's up in the resource tab on the top right, which you can get any one of these evidence-based guidelines for anything you may see. We have an entire myriad of obstetric ones. There's a ton of neonatal and infant ones as well. And we look over those every year and make sure that they are still evidence-based and with the most recent recommendations. This is accessed by 48 out of 50 states and 38 countries. 69 of our 75 counties throughout Arkansas also address and kind of tap into this network. There's also an outreach piece. We try to coordinate the care. If there is someone in a small rural town that has an infant with anomalies, that we coordinate that care with everyone that needs to be involved in that infant care. If that infant can deliver there and we coordinate that care here, we try to do that. We know that it's better to deliver in your own area. If we need to deliver them here, then we try to coordinate all of that. So there's a big piece of that. There's a 24/7 consult service, so you can talk to one of your colleagues around the state, one of our obstetricians or maternal fetal medicine if there's a question or concern that comes up. And then there's also remote telemedicine sites that we have throughout our state with which we also do telemedicine visits and teleultrasounds. We have a sonographer that goes around the state and does high-risk OB ultrasounds that are then read by our maternal fetal medicine doctors. So we really try to avoid the emergency room if possible and kind of coordinate that care. Now, sometimes they can do this with their own devices at their own home and don't even have to go to a clinic. So this has been a huge asset to our state. Power. This is also a kind of tendril that's built off of this. And this is a big part of those safety bundles that I talked about. We're going into these, oh goodness, now 35 delivering hospitals in our state and doing virtual education sessions, interactive videos. We do simulations and workshops and kind of walk them through, a postpartum shoulder dystocia for people that actively do it. What are some tricks for a postpartum hemorrhage? Here are the drugs. Here's what you should have in your toolbox at home. For postpartum hypertension, here's you don't have to, anyone along this line can start this process from when they hit the door, and here's what the standard of care are. And let nursing even do that. It's protocol driven and no one has to practice kind of off the cuff. Centering in pregnancy. So this is really kind of neat, and it started here in 2019 after much planning. It is group-based prenatal care. And now some people kind of misunderstand this, that it's an education. It's not. It's the actual prenatal care visit. So in lieu of coming to the traditional once a 4-week prenatal care visit, they attend prenatal care with a group of very similar gestational age individuals. So usually within 4 weeks gestational age, it's a group of women. Sometimes there's husbands. We have teens. We have diabetes. And so it's a group of very like gestational age individuals, and it is 2 hours long. Now that may seem daunting, and for anyone that's had a baby or mom, wife or whomever, you're like, God, I can't spend 2 hours in a office visit. But if you really think about it, by the time you go check in, you wait in a waiting room, you go see them. It's been an hour 15 to an hour and a half. With these group prenatal care visits, we are able to give so much more information. We talk about child safety issues. We talk about breastfeeding. We have mental health specialists that come in. We have social workers that come in. There is so much bonding, and what it does is it gives the women more ownership over their pregnancy. They dip their own urine, they check their own blood pressure, they understand more of what that means, and with that, they can make better choices for themselves. It also creates a community. For many of our patients, they don't have that community at home, so it creates that for them, which they can then lean on. We have seen significant improvement in our breastfeeding rates. We have seen a decrease in our preterm labor rates. So it is very time consuming to do this, but it is such a, we have seen the benefits to the health outcomes for these women. We have also gotten a grant most recently to do centering and pregnancy in a mobile unit that we do now go into the Delta and do group prenatal care visits with the help of our colleagues around the state. And so all of these look a little bit differently, but the idea is very similar in that it creates a community and it gives women the opportunity to kind of take more ownership over their health, and hopefully will make better choices with that knowledge that they get. Um, and this is that centering and pregnancy in the Delta area that I kind of talked about. This was a grant, a HRSA grant that we got recently to help assist this. With this, we got these mobile units, and we hope to use this for many other things going into the future, and including some hopefully contraceptive outreach clinics throughout the state with this. But this grant has given us the opportunity to kind of build on this, as well as an entire piece for our emergency providers. As I talked about earlier, with these delivering hospitals closing, more and more patients will present to their local emergency rooms for whatever obstetrical emergency. And so, how can we better support our emergency doctors around the state to know, if is this something I can take care of? Is there something that I should do differently? Who can I call to when I I don't have the resources within my community hospital to deal with this? So a lot of this will kind of piggyback on this HRSA grant that we were able to get. Remote patient monitoring. We have been using this for some time, but I think COVID really bumped up the game with a lot of this stuff. And so, how can we better use technology to let people stay closer to home? And we have a number of different studies and programs that we do that with regards to blood pressure cuffs, with regard to glucose monitoring. We have a new one with regards to temperature evaluations in the postpartum period to address for early sepsis. We have weights, which then will feed that weight so that we can hopefully see if they're at risk for postpartum cardiomyopathy, or during pregnancy, are they at risk for preeclampsia? Have they all of a sudden gained 5 pounds within 4 days? And this is something we need to address in a different way, and that gets fed into a call center based on whatever grant we're doing. And so hopefully we can see how we can better serve areas of our state, maybe without them having to travel these long distances, but giving them that care a little bit closer to home. So community-based programs. So much is based on these community supports that they have in this area, in their particular area. And there's lots of work being done on this. Following baby back home, if they deliver here, when and how can we get them back into their communities? We know families, cannot afford to have their babies here or in a faraway hospital. When is it safe? How can we get that coordinated? Healthy Start really improves that. It launched in 2019 and has since provided services for over 1,000 families. It does referrals for mothers in children and looks at different areas of disparities and tries to coordinate those services for those families. And then how can we train more community healthcare workers? How can we get more boots on the ground helping these families kind of tackle how difficult it is to sometimes work in our healthcare system and get them the resources that they need. And so there has been some grant work in training more community healthcare workers as well. So this is a particular kind of baby of mine. ACOG, or American College of Obstetrics and Gynecology, came out and said, long-acting reversible contraceptives in the immediate postpartum period should be a standard of care. What we learned is that for anyone that does deliveries, that health care is bundled into a cost, right? So there's a finite amount the hospital gets for each delivery, whether it be a vaginal delivery or a C-section. If we place a LARC, that was for many patients eating into that bundle because most insurance providers would not cover that cost outside of that DRG, outside of that bundle. As many of you know, these devices can cost anywhere between $500 and $1,200. We know they're highly reliable. We know that they're highly effective. We know that it'd be ideal to be able to place them in a postpartum period on a patient that already has an epidural or before they leave the hospital. We also know that 50% of our patients don't attend their postpartum visit. So we're missing this huge opportunity to discuss contraceptives. And over 50% of pregnancies in our state are unintended. So how can we help them in a different way? So we were able to get an initial $150,000 grant, and we offered these devices to everyone that wanted them. We talked about it during their prenatal care, and then if they wanted a device, whether it be an IUD or a Nexplanon, we placed it within their immediate postpartum period. If their insurance covered it, we billed the insurance. If we didn't, we billed the grant. We did not charge the grant for physician costs. Being that we're UAMS, I was able to kind of do that on our own. And so we were able to show the data in the last legislative session, and we beat national standards for expulsion rate and removal rate. And so in April of 2023, we passed Bill 1385 that mandated all insurances to cover this in the immediate postpartum period, which is huge. Medicaid has, so January 1st is when this went into fruition. We now have another grant that we are actually going to go into all of our delivering hospitals in the state and kind of help them institute this. I think for most people that do deliveries, they don't need help on how to place them, but there will be a billing and coding piece that we're going to add to this such that they can do clean claims. They have someone that I can talk to. I'm going to create some videos such that they have access to how to place it, how to bill for it, how to get reimbursed for it, and just make this as easy as possible for our delivering hospitals throughout the state. So hopefully this will have a huge impact in unintended pregnancies and that pregnancy spacing that I talked about, in addition to giving women kind of ownership on when they want to get pregnant, and if they want that in the immediate postpartum period, that they should be able to get it. Okay, so some opportunities for transformation, and this, even since I have done this, has changed slightly. We are now on one of only 8 states in our nation that has not extended postpartum care to 12 months. And what I mean by that, a patient that has Medicaid during their pregnancy, which is it's close to 60% of all births in our state are still covered by Medicaid. They lose coverage at 60 days. So as you can imagine, 60 days, you're still pretty upside down. You don't know which day it is. You're barely taking care of yourself. Everything you have is kind of going towards taking care of this baby and what's your family look like, and life is very upside down. Hence, over 50% of women that don't attend their postpartum visit. Well, what happens is they lose coverage at 60 days. So That mental health support is not there after that point. Their preventative care services, getting them in better shape for chronic hypertension, diabetes, obesity, some of these things we know that have a poor health outcome for subsequent pregnancies, they're unable to get that done. In addition to contraception, that's a huge point in time that we talk about, what do we want to do for future pregnancies? So extension of Medicaid to 12 months or longer is a huge goal of ours in this state, and we are now one of 8 states that do not have extension of these services. So huge opportunity. The long-acting immediate contraceptives. So how can we get this, like I said, now that we have this bill, how can we institute this more throughout our state? What do you guys need in order to feel more comfortable? Is it more education? How can we support that? Is it more of our FQHCs being able to place it? Is it so really getting to the nuts and bolts of how, if a woman wants it throughout our state, how can we facilitate providers to place these devices that we know are highly effective and reversible, such that they can, kind of decide for themselves when their families are complete? Invest in our maternity work care in rural areas. So this has been, and I know for many of you guys, this has been kind of part of the discussion. How can we support more family medicine physicians doing obstetrical training, knowing that it is what keeps you out at night? It is what, you know, call, liability, everything that goes along with making this riskier. How can we support that? Reimbursement is also a huge part of this. And so there's a lot of discussions based on this. Every year I have areas of our state that reach out to me and ask for obstetric and gynecology providers. And yes, I think there is so much of a need for obstetrical care, but it's really hard for my residents that do obstetrics and gynecology. Many of these small communities cannot support the gynecology. They don't have the ORs, they don't have the laparoscopic equipment, they don't have a lot of that stuff for the other half of what my residents are trained to do. And so they go to places that do have those. So which is creating a larger and larger gap with regards to obstetrical training. So how can we support that for you guys? How can we support more certified nurse midwives in the workforce? We have come a long way. When I was in residency, we had certified nurse midwives that worked very siloed from us. We had our team and their team, and we were not allowed to kind of look to their patients unless they asked us. As you can imagine, this does not work out very well. And so there were a few poor outcomes, and that service completely went away. We brought them back in a very different model, and we now work so collaboratively together. They are huge assets to us. They provide very safe, effective obstetrical care within these bumpers, which is what we really need in our state. How can we safely take care of people within this, but then know that there's a referral if it gets outside of what we all feel comfortable with? So how can we partner with our obstetrical providers to show them kind of this can be a very collaborative situation? By putting a midwife in a hospital in a silo is never going to work. We can attest to that. Doula services. There's a lot of discussion on doulas throughout our state. And for me, doulas kind of serve that role of a community healthcare associate. They help support the pregnancy. The goal is to not necessarily practice the medicine, which is left to the providers, but help support them in the, prenatal care, whether that be access to food insecurities or resources, but especially in that postpartum care and how they can be heard in a different way and be able to have avenues with which they can kind of escalate that care if they need to. There needs to be some policies and protocols based on this. There needs to be a national registry of this. And so there needs to be some work with regards to this before before those services are completely covered. But I think it really aids in how can we better serve our community healthcare workers and support them in ways that will support our families. It's really just having an advocate, right? Um, Expanding. So other opportunities, obviously the remote patient monitoring, what have we not thought of? We're trying all kinds of different things. And luckily, like I said, there's a lot of grant money coming towards this. So we're looking at things in different ways with different twists and seeing if it really does improve some healthcare outcomes. Um, we were able to get a PCORI grant recently to address postpartum care. You know, we've always done this traditional postpartum care where you come back at 6 weeks, we check you, we talk about a myriad of things, and then you go on. Is that really the best? None of it's really ever been validated. Should we really profile people a little bit differently? And so we've gotten this grant to kind of address that. Is it better to see some of these XYZ diagnosis at 14 days, at this many days? So we're going to do some work over the next 5 years to kind of address that and tailor the frequency of care, if appropriate, to what it should be. So we are starting, it's going to be February. I thought it was going to be January, but it's probably going to be February before we start enrollment on this. And that is all for me. I've kind of like thrown out a billion things that we are working on, and I'm super excited about. A big part of my job now is kind of some advocacy on a more statewide level. And there are so many people around our state that really want to help. And so, how best to kind of work through all of that and get it coordinated and organized such that we're not all doing the same thing or doing things that don't talk to each other. And so, more to come on that, but if there are any questions, I'm happy to talk about them, or if concerns or areas that you just kind of want some more clarification on, I am happy to talk about any of that. Okay. Well, I don't see. I was told to give a few minutes for questions. So please ask me anything if there's something that um, I can help with in any way. Yes, so we are hoping to partner with Upstream in the primary care service line to help increase access. So yes, I've actually talked to Upstream as well. Upstream is a group that is a national group, and they get their funds from private philanthropy. They come into hospitals and offer educational services to staff. It's more the ancillary staff, a lot of the nursing, a lot of the, some of the physician work as well. I think that will be hugely beneficial. I think also, as my goal, so discussions on contraception are long, right? There's so many different things out there. So I think a lot of times, as you all are constrained with time and you have 15 minutes with a return patient or whatever the case may be, sometimes these conversations don't get to happen as much as you would like for it to do. I would love for us to create, and we have a few different kind of like videos, or how can we better support you guys in these discussions so it doesn't add to your days, but you feel comfortable to discuss the different forms of contraception. And then also, how if you don't feel comfortable placing them, can I get you to feel comfortable? And I'm happy to work with anyone that wants to do that. There will be some other work, as you guys will hear about in the next coming months with regards to this. But I think, to the initial question, I think upstream has very good ideas, and if it will increase our utilization of long-acting reversible contraceptives in our state, I think it will be hugely beneficial. And please reach out to me if there's anything you need from us. Another question is the rate of suicide among postpartum women, is it different for first-time mothers versus multiples? I don't have that specific information. I know it's significantly elevated over the last 3 to 5 years, but specifically for the last 3 years. And as you can imagine, COVID pandemic did not help this. It increased isolation. It decreased access to resources. And I mean that with regards to jobs and transportation. And so we've seen an increase in our substance abuse. And so I don't have whether it's different necessarily with a G1 versus, a multiparous mom, but I do know that it's a significant issue. And, our valiant maternal health care workers, maternal mental health care workers are working so hard. There is just not enough people doing this work right now. So, question, is there a central source location for the toolboxes you have mentioned? So the toolboxes with regards to kind of those AIM bundles, there is, and I can, if you were to Google healthycareforeverymom.org, there is access to all of those toolboxes, but our goal is that Power will help support your communities and give the appropriate toolboxes with everything that you may need. And so they should be doing that pretty real time. And I know they have a rotation of the hospitals they attend, but if you have not or need additional, please reach out to me and I will make sure that that gets facilitated. Are there any freestanding birthing centers in Arkansas? No, not that I know of. There used to be up in Northwest Arkansas, and the last I heard, that has closed. So there is not any freestanding birthing centers. UAMS, in order to kind of help support moms that want very little to no intervention, have started a low intervention program. We started this probably about 2 years ago. We have a certified nurse midwife program that will help also with low intervention. Baptist has since done something like this. We know that 30% of complications in pregnancy are unexpected. So we do not recommend home births. We obviously would love for them to deliver in a hospital and want to support them in whatever their choices are with regards to the amount of intervention that they want and need. And so I think there's more to come on how we can kind of get the word out to low intervention in hospital births. There's also been some asks from different legislators whether there could be a freestanding birthing center or could we support that. And I think in order to do that safely, it should be somewhat attached to a hospital. With those 30% that are unexpected, when good goes to bad, it happens really quickly. And so being able to have access to that higher level care is what's going to make a difference in those. Let's see, what can we in our approach to medical education to help bring awareness to disparities of health in the minority population? I think that's a great question. I think first saying that there are disparities, I think tit for tat, Black women in our state do worse. I think recognizing that that is a problem. And this is not to point blame or say fault. I mean, it's different. And so I think now, as I have a patient that presents to my office, if they are in a group that I see significant disparities of health, I have to recognize that I may need to listen to them in a different way. And it may get jumbled into what they're saying and how can I decipher that in a different way? And I'll put a question. I mean, I'll give an example. I get, pregnancy is very unique. There's so many aches and turns and different things that happen throughout pregnancy. And some women ask a ton of questions, some women ask no questions. Now with my chart, it's so easily accessible to ask questions for good and bad, I guess. But I recognize now that I have to read into it somewhat differently. And I think teaching our residents and our learners that at a very young and impressionable point in their careers, that even though we may have had this question asked to us 5 times in 3 different ways, coming from someone that is in a group that we know is not doing as poorly, we may just need to listen to. The Hear Her campaign is another thing that I think, it talks about, are you having shortness of breath? They seem very simple, to us in healthcare. Do you have a fever? Have you checked your blood pressure? Are you having headaches? Like, check these things. And if it's weird, go to your healthcare provider. But also, if you don't get what you need or if you're still having this and not getting resolution, I need you to escalate it. And how can we help empower these patients to kind of escalate that care? So I hope I answered that question. If I didn't, please let me know. So let's see. What are the steps needed to incorporate family physicians into the work of improving maternal and fetal outcomes around our state? In other words, how can family physicians become a part of we? I think you are a part of we. I think how can we work together to do that, knowing that y'all are the extension of us in the communities that will see them for the longevity. Sometimes women don't ever come back to us. And you guys are providing a large part of that. And so, you know, how can I or we at UAMS, meaning the obstetrical and gynecology departments, serve your groups in a different and better way? Is this helpful? Is it coming in person and doing some LARC trainings or some contraceptive talks, or here's what I think about abnormal uterine bleeding in a gynecology patient. How can we become resources for each other in a better and different way? And I think, we haven't tapped into our regional programs the way that I feel like we could. I think there's so much more that we could do with regards to that and becoming extensions of one another in that respect. But I think for those that practice obstetrics, like, please know please reach out to me on how we can become better resources for you. And I think that's very different for different parts of our state. And that's okay. Again, I have access to a lot of different grant funds that we never really had the opportunity. So let's take some of that money and make it starter programs to really see how we can improve some of that stuff. So that's the kind of things that really make me excited. Let's see. The chief medical officer in our hospital is despondent about hiring any obstetrician willing to take call. He says there are several specialties where new graduates are refusing to take call. How are we going to provide good obstetrical care with these doctors? I mean, I think that's a good question. Lifestyle plays into a lot of what our new residents are thinking about and doing about. We have been super fortunate that we still have a huge group of people that want to do obstetrics. Our residency program is not having any problem with filling slots, and we're getting great candidates, but lifestyle is increasingly an issue. So I think when we talk about these things, we have to think outside of the box. No one wants to do the old school way of taking call every night and being on for indefinite number of deliveries. And I recognize some of these hospitals may only do 300 deliveries, but to be on call and not, have a drink with your family or whatever the case may be is a big deal. I really think there's ways that we can collaborate with some of our certified nurse midwives coming into the communities and providing some safe call. Are there ways that we can support with different mid-levels? I mean, some of it's the triage. They come in, they don't need to be admitted, but to go up there and assess them and do that. there are models that have been tested that work well, recognizing that people just don't want to be on call every night, nor do I. I mean, I would not want that lifestyle, and I know many of you don't either. So how can we expand on some of these other groups that can provide safe obstetrical care, including the night call coverage, in a fiscally responsible way, that will also give the patients what they need? So I think there is work that could definitely be done there. How do interested hospitals, clinics schedule centering pregnancy classes? Reach out to me. Um, we would be happy to discuss this. We're hoping to do probably about, 5 to 7 more programs in the next year. So please reach out to me. I think my information is global, but you will never be bothering me at all. Please reach out to me, and I will help you with that. What is the first step to start the process in developing high-risk telehealth visits in our clinic? Again, reach out to me. We have funding for that, and if that is a want or a need in your hospital, in your community, then we will do our best to make it happen, and I really think we can. I love all these questions. Okay, obesity is a risk factor for maternal morbidity and mortality. Absolutely. What metrics are the Arkansas Maternal Mortality Review Committee collecting to quantify the risk for maternal death by pre-pregnancy, pregnancy, post-pregnancy BMI to determine whether obesity affected the quality of care in these? So that's not necessarily in the realm of the Maternal Mortality Review Committee. We've looked through every case. We certainly note what their pregnancy, there is an abstractor that gathers as much information as they can based on that pregnancy, including like some social media searches and other things. And we certainly sometimes will get a pregnancy BMI, but quite often don't have a pre-pregnancy BMI. We do have a list of other medical diagnosis, including diabetes, pre-gestational diabetes, gestational diabetes. Were they on insulin? And so, with regards to the Perinatal Quality Collaborative, which is one of the first slides I showed, which is part of the AIM bundle that we became, there will be additional amounts of data that we can hopefully look at with regards to obesity and other pre-existing conditions. There is also another grant that we recently received that I don't think has been publicized yet that will specifically look at weight gain in pregnancy and its development of gestational diabetes, as well as health outcomes, as well as if certain dietary changes could affect those things. What about the model of nurse midwives supervised by family medicine with a good plan for? I love that. I think there could be, and sorry, I may not have said that all the way. What about the model of nurse midwives supervised by family practice with a good plan for long distance rapid transports in cases of emergencies? I think there's so much potential for that. And we already have the bones of it here, right? So we have a working document that we address regularly, but look at annually. That is, for lack of a better way, okay, these are what nurse midwives can deal with all by themselves. Here is what we need to consult on. Here is out of the, this may be a co-dependent situation, and this is what all the obstetricians need to do. And I think we could very easily adapt that to a different scope for what you guys would want. So I think the bones of that is already there. And I'd love to talk more about how we could put that into fruition. Have you considered changing your program to train obstetricians to not only do gynecology and therefore to not do gynecology and therefore might be willing to work? Well, most of them want to do gynecology. I mean, again, it's a big part of why they go into obstetrics. There are some that don't, but most of them, if they only want to do, so there are some some different pathways that we have outside of residency, and you can kind of concentrate more on obstetrics and concentrate more on gynecology. The ones that concentrate more on obstetrics kind of become our high risk, moderate risk people. And so they kind of deal with the higher risk things that I don't know. Not that it doesn't lend itself. It absolutely lends itself to rural communities, because I would argue there's a higher portion of high risk, but there's not many trainees that I have that go into obstetrics and gynecology, or that have presented to me that don't want to do the gynecology. But certainly something we could talk about. What can be done to address obesity as a risk factor among pregnant women, especially with existing programs, resources, and what are the gaps? I think a big part of this gap is extension of postpartum Medicaid, or extension of insurance coverage. There are resources that they have. I mean, now we have weight loss medications that many of them could absolutely apply for and qualify for, but they have no resources with which to do so. Many of them would qualify for Medicaid, but it is a very cumbersome application process. And so we're working on ways in order to make that easier and better, so that we can get more patients covered. And how can food insecurities? I mean, we all know it's cheaper to buy a Big Mac than it is to go and buy fruits and vegetables for your family. And so there is a lot of work that needs to be done in some of that equity. And how can we support them when they are working to make good health choices for them and their families? How can we cut coverage for some of the medications that we know will make a difference in their lives, whether it be diabetes medications or weight loss medications? And there's a lot that we could do in those. Question: who removes the birth control devices once placed? So that's a great question. Ideally, who places it? But I think part of one of the grants that we're doing on is not only getting people more comfortable with placing and removing, but dealing with the complications. And making sure we have a very visible site with which any provider, if they don't feel comfortable, say you play an Nexplanon, but you're like, I can't feel it anymore, I'm not comfortable taking this thing out, or the IUD, the strings are lost, I mean, you're like, I don't feel comfortable digging up in here. I'm going to make a list of places, hopefully, or me as in the royal we, of where you can send patients to. And then if I can help support them in different ways, or train up faculty or providers, we're going to do that. So I hope to have more on that in ways of kind of with this one grant that I have going into all of the delivering hospitals that will place the long-acting reversible contraceptive devices in the immediate postpartum period. I will create a website, and hopefully this will live on there. Last question, I guess. Off the cuff, let's see, would you say maternal mortality is more physical complications, behavioral health, integrated care would greatly benefit efforts to improve? I think it's all those things. I've talked about, so the question is it more physical or mental or behavioral? And I think depending on the bucket with which we are seeing maternal mortality is very different. I think there are very physical complications in those first, I would argue, birth or hospital stay to 43 days. And then there's a lot of behavioral and mental health and depression and substance use in that further part out. So 2/3 of it, I would say, is probably some of the physical things. And I'd say at least 1/3 of it is behavioral and substance use. Well, thank you, guys. This has been delightful, and I love the questions and I love the interaction, and I hope this was helpful. And please reach out to me if there is anything I can do or my group can do to help. I'm constantly got my hand in some different idea, and so I would love any more ideas or how we can support you guys and your programs to help kind of support maternal health care in our state. Thank you.